Welcome to the ABCs of MIPS, our monthly broadcast looking at how the merit-based incentive payments will impact your bottom line. I'm Carol Flagg of IT Answers. Thanks for tuning in. On this program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, VBM, and more. And of course, under the macrofinal rule, we are now talking about the quality payment program. And today we're going to be addressing your questions from the last session and from this session and questions we've gotten in between, which are numerous. We'll get to them as many as we can. Our experts, of course, are from SA Ignite, and they include Beth Hauk, Matthew Barron, and Matthew Susan. So with that, I'm going to turn this presentation over to you guys, and we'll come back at the end if we've got time for Q&A.
That sounds great. Thank you so much, Carol, and thank you everybody for listening to us again just a week after our original presentation. We received so many questions during that presentation last week that we thought probably the best way for us to really teach you again more about the regulations was to address some of the hot categories and kind of edge cases that really kept coming up over and over again. So today what we're going to do is go through those questions. I'm going to have my two Matts help provide information during all of that. So you'll have kind of a panel of experts, and then certainly if we have time for additional questions at the end, which I'm not going to guarantee, but if we have time for additional questions at the end, we'll go ahead and answer them at that time. So please don't hesitate to continue to chat in questions because, again, those might be fodder for future presentations, but we are going to try to cover as many of the questions that we've collated here in this presentation as possible. So just to give you a sense of some of the topics that we received questions on that we're going to cover today. First, we're going to cover some questions, some hot ones for the quality category. Again, some other ones that are hot questions and topic areas for the ACI category. We're going to spend some time on reporting and submission. So a number of questions about how that might impact just all categories. There were some individual questions about audits, caps, financial impact clarification, some about multi-location EHRs or really practicing at more than one place. And then if you can imagine, there were both exception providers, which I would call, a lot of the specialty, fill in the blank, like what happens to my fill in the blank radiologist, pathologist, anesthesiologist. And then there were some special categories of groups of providers that we're also going to try to address. So again, lots of things for us to cover in this. So we did make one trade-off, which is you'll see that APMs are not listed on that whole list simply because we didn't feel like we could do it justice and really cover all of these questions as well. So I'm going to start by talking about the quality category, and I'm going to actually address our first question. So the first question we got was to explain what data completeness meant, and then that fundamental understanding launched the next couple questions. So data completion is the way that CMS looks at whether or not all of enough data has been reported by a particular provider that best reflects their overall quality. So this data completeness value comes into play in the quality category. So the discussion was, what's the right number or percent of your total patients that CMS wants you to have reported in order for them to feel like that really addresses truly what the quality reflection of that provider is. So in the proposed rule, what they said was that that threshold would be 90% of all patients. And what they agreed to in the final rule was that it would be 50% of patients. Okay, and so that's 50% of all payer patients. And so what that means when you're actually reporting a measure, it's 50% of those patients for whom the denominator applies. So you're not, kind of penalized for not having the denominator value of that measure not applying, and we'll address that later on, but it's 50% of your patients. That data completeness threshold goes up in the next year, so that'll go up to 60% in the following year. So that rolls into the second question, which is, did the final rule address eliminating the cherry picking of which patients are submitted? So because of that data completeness threshold of 50%, it means that you don't have to submit data on 50% of your patients, which ultimately could mean that you could cherry pick the patients for whom you got better numerator scores than the ones that didn't. So by the rule, I would say that that didn't necessarily eliminate the cherry picking of the patients. You could still, with some analytics, do some cherry picking to pull out the patients that really are positively impacting your numerator. And then the last question, which is, are we only reporting for Medicare patients or for all patients? So this depends on your submission method. So there are a whole bunch of different ways that you can submit the quality category. Most of those ways that you submit via the quality category will cover all payers. So it will Medicare plus everybody else. So that's QCDR, that's any of your registries, EHR Direct. For claims-based submissions and for CMS web interface submission, in both of those cases, those are going to be Medicare patients only, mostly because of the type of submission that's going on. So we're going to move over to the benchmark category, and Matt Baring.
Yes, absolutely. Thank you, Beth. Beth, audio's coming through good for you?
All good.
All right, excellent. So the first question we had was whether or not the decile benchmarks for quality measures were publicly available, and how is this different than the benchmarks we have now. So the benchmarks are not yet publicly available, but CMS has committed to making benchmarks available prior to the beginning of the performance year. So this differs quite a bit from what we experienced under PQRS and VBM, where the benchmarks were reflected in your QRUR reports once they were released about 10 months after your performance year. These measure benchmarks for MIPS are going to be based on historical performance for each of the measures based on a baseline period. The one exception is web interface. Benchmarks will be the same under web interface as they are for the shared savings program and not the benchmark year. But again, those benchmarks will be known in advance, so you'll have a better sense of kind of what your targets that you're marching towards are, which we think is definitely a good thing. Another question that we had was, if you report via web interface, are you compared against groups that report via EHR? So this is one of the departures that the MIPS program has from PQRS VBM. Under PQRS VBM, the same benchmarks applied regardless of what your submission method and reporting mechanism were. Under MIPS, each submission method has its own benchmarks. So folks who are submitting via EHR Direct will have a different set of benchmarks than folks who are submitting via the registry method, and so on and so forth. So there'll be a bit more strategy that goes into figuring out which reporting mechanism is best for your organization, because there's some opportunity for higher scores depending on how you're structured and what it is you're seeking to achieve. The final question here in this benchmarks category was, when will the CMS 2017 benchmarks be available? And the most specific that we've got from CMS is that it'll be before the performance year. So hopefully these aren't rolling out at New Year's Eve party, but it could be up to the 31st of December. And with that, I'll pass it over to Mr. Fusen for measures and scoring.
Great, thank you everybody. Are the measures in the quality category CQM measures or PQRS measures? And it's actually a combination of both. So the list of measures that are available, are over 270, and it combines CQM and PQRS. If we send in data via two different methods, will CMS take the best 6 quality measures, or will they combine all of them? So this is kind of a two-part answer. First, per the regulation and the rules and the requirements, you cannot submit via two different methods for the same category. That being said, CMS did build in a kind of safety valve check in case somebody does do it by accident, and what they will do then is select the highest measure, so the highest point total for a single submission. They will not blend them together. So per the requirements, you really shouldn't do it, but if you do it and you submit 2 different ones, they're going to take the highest score. I think we can move to the next page. And here we have ACI category and within it the breakout. So from a measure perspective, did CPOE and CDS make it as measures as part of the final rule? And the answer is no. They did not. So they were proposed to be removed as part of the proposed rule, and that was finalized. So they are not part of the final rule or ACI category. And are there still exclusions for measures? And the answer is no, there is not. There's a lot of other exclusions as part of the overall rule that would potentially, you wouldn't be participating in ACI, such as non-patient, or I'm sorry, hospital-based clinicians and low threshold volumes and all of that, but nothing specific to the measures in this category.
Thanks, Matt. So just to add on a little bit to what Matt just said, too, is one of the things that CMS said was the reason we're putting so many more measures out there, we're allowing for more points. So a total of 155 points in the ACI category, and you only require 100 points to get 100% of the score, is that they didn't want to include the exclusions. So the exclusions aren't in there because they're saying it's okay, you can pick something else. So the question, so leading into that, the scoring, if I have a 0 denominator for health information exchange, thus a 0 numerator, do I receive a 0 on my base ACI score? So the unfortunate answer is the yes. So you do have to have a minimum threshold of 1 on that measure, because that measure is considered part of the base measures, in order to get a score at all in the ACI score. So they do address in the rule that they believe that everybody should be able to do 1. I think that the comment period still is open, so if there's a situation where you don't think that the measures do reflect what all of your providers can do, then certainly you can send that in. And then it is possible that if it's a provider that can't do that, might be a type of provider that's actually eliminated from the ACI category overall. So I think that was based on their analysis. They believe that all the providers that were eligible for the ACI category could do this measure. If providers are reporting as a group, are their individual MU scores combined together and averaged to determine a score? Really good question, because it made me think for a second. So are you calculating ACI scores and averaging those, or are you looking at the numerators and denominators? So the answer is that what they're saying is you will sum together all of the numerators and denominators if you're doing a group reporting, and then calculate your ACI score from there. So you're not, kind of weighting people that have low volumes higher than what you should be. So you are totaling that and then creating an ACI score. They also do address the concept of unique patient count. So they recognize that it is possible that if you only have individual measure reporting that you have to then total in order to get to that group total, that there is the possibility that you would be double counting a patient, so unique patient count won't be accurate, and they say that's okay. So they recognize that the EHRs may not yet report at a group level and include the unique patient count information. And then the last question, how do the 20 points work for the provide patient access measure? Do you just double the score for that category? From my read of how the points are scored, you have it correct. So it's you get 20% for that particular measure, for those of you that don't have it in front of you. But basically for 2017, there are a couple measures, provide patient access being one of them, where they doubled the they doubled the amount of points that could be earned on that measure, because they don't have enough modified stage 2 measures to come up with the full 155 points. So the way that they addressed that was by adding additional, or doubling the amount of points that could be earned on a couple specific measures.
Great.
Go ahead, Matt.
Thank you, Beth. Thank you, Beth. So on the bonus points front within the ACI category, we received a couple of questions that we wanted to draw attention to. So the first one was just fundamentally how are ACI bonus points earned? And there's two ways to earn bonus points under the advancing care information category. So the first is improvement activities that utilize certified electronic health records, and those can earn up to a 10% bonus. And then the second way to earn bonus points is for reporting to a public health and clinical data registries beyond just the basic immunization registry reporting measure. 4 advancing care information measures are particularly relevant. If you want some more information on those, they're on page 847 of the rule, and that's captured within table 9. But the 4 of them are syndromic surveillance reporting, electronic case reporting, public health registry reporting, and clinical data registry reporting. So improvement activities, and then also reporting to the health and clinical data registries. On the second question, specifically, how are the 10 ACI bonus points earned for doing a CPIA activity? And CMS will award a 10% bonus in the ACI category if a MIPS eligible clinician attests to completing at least one of the improvement activities that are specified in Table 8 of the final rule. Table 8 is on page 788. That table contains information about each of these activities. Each of the activities is worth 10 points with double weight for high value activities. So there are 3 activities that are deemed high weight. Those are worth twice as much as the others. So completion of these, example, providing 24/7 access to eligible clinicians, population management, there's care coordination. There's several different categories, each of which drive the accumulation of those bonus points. So I think we can move on to that next slide. On the reporting and submission front, one of the questions that we saw quite a bit was, can I report different 90-day periods for the different categories within MIPS? And that is, the short answer is yes. So you can select different 90-day periods across each of the 4 categories. It's up to the MIPS eligible clinician's discretion whether to submit the same data or different data over 90-day periods. So it's nice to have that level of flexibility. On the reporting options front, do we have to choose one reporting option for all MIPS categories, or can we choose group for some and individual for others? One of the firm rules of the final rule is that you must choose the same submission method for all 4 categories. So if you want to go GPRO, you have to do it across all 4 categories. Same for individual provider. Can you choose to report via individual 1 year and then report via group the next? And that answer is yes. The decision is made on an annual basis. So you can evaluate your organization over time and make the decision each year which is best for you for that performance year. Finally, is it true that we will be able to report both individually and as a group, and that CMS will use the best score? Is that still an option in the final rule? Per the MIPS final rule, MIPS clinicians can only submit via one submission method or the other. You cannot submit both. You cannot submit both individual and GPRO. Got to choose one or the other. With that, I will hand it over to address these submission options.
Yeah, thanks, Matt. And I can't resist adding one additional little note, which is, in the can you choose to report them individual 1 year and group the next? Again, I'll remind everybody that you no longer have to make a declaration like you have to right now. So the only time you need to make a declaration is when you're choosing to report via GPRO web interface. That method you do have to report by the end of June like you do currently, but any of the other methods you can make that decision of group versus individual reporting at the time of submission. So that doesn't have to be made ahead of time. So submission options. there are so many different options for reporting, and I think that is part of what gets confusing. So there's two different paths we're talking about. So there are reporting options, meaning individual versus group, and then there are submission options, which means, do I submit via EHR Direct, do I submit via registry, do I use CMS web interface, or do I use attestation method? So while you do have to report individual or group as a whole across all the categories, and I almost said all four categories, all three categories, you don't have to choose the same method of submission for all the categories. So you can submit one method, and you can submit another category, another method. So I just want to point that out. If measures group reporting has been eliminated, what is the process for reporting quality measures? I thought this was worth, this question, although it's very specific to those people that have done measures group in the past, I think it's representative of some of the concerns and that we saw across a number of questions, which is measures group reporting is a type of reporting where you only had to report 20 patients. So you picked 20 patients and you did a specific type of reporting for that, and that counted under the PQRS program. That particular reporting method is no longer going to be applicable, and part of that is because of that data completeness that I was talking about before. So for those people that previously used measures group, you will have to start to look at some of the other methods that are available to you, probably because these tend to be smaller practices, probably looking at EHR Direct and Registry would be two main routes to go down right away. Will CPIA be submitted in the same way as ACI? So this is almost a leading question. So they all have a number of different submission methods that they've listed as being potentially allowed to submit via. So the rule itself will say that you can submit your ACI measures via EHR Direct, but there aren't any specifications yet built for doing that. So the number of ways you can submit the measures is actually quite broad. But what you may be referring to, or the person when they were asking this question, what they may be referring to is, it sure seems like the way that you're looking at the CPIA measures is the same way you generally have attested for meaningful use in the past. So one of the methods for submission for CPIA is via attestation, which is, yes, I did this, or no, I didn't, or yes, I did this, and potentially here's the documentation to prove it. So our just pure conjecture is that it will be likely that there will be some kind of attestation, or I guess for sure there will be some kind of way of attesting for these measures, because that's listed as one of the submission methods, but there may also be specifications for other ways to submit the information to CMS. So you won't necessarily have to submit it in the same way as ACI, although it's likely to be similar. And then the last question is, what is the difference between web-based and EHR reporting? So much of this is lingos, and so much of it is understanding, kind of the historical, many different ways to submit your PQRS information. So basically what I think the question asker was probably referring to is the CMS web interface method, which is varies pretty differently from EHR Direct reporting. So under EHR Direct reporting, your EHR is calculating your measures, and it's putting those in a numerator-denominator format. It's calculating those measures based on data that's been put in discrete data fields. And then ultimately, that data gets put into a standard file format called a QRDA3, and that QRDA3 then can be submitted to CMS. And so that's kind of a pure electronic submission of your CQM data. The GPRO web interface method, the CMS provides you with a list of patients, and then you go and then you have an accompanying list of measures, and you need to go into those patients' charts and find out what the numerator is for those particular measures. But you don't necessarily need to look in a discrete data field. You could potentially be looking in the notes. So the difference in how it's counted is very different, obviously, and then methodology-wise, you can also see that that's quite a different undertaking.
Great, thank you, Beth. We received quite a few questions on the audit front, which probably denotes more fear about the audit process than excitement for it. Primary question was, has CMS discussed how they will approach audits for MIPS? So the short answer is that not really. In CMS's own words, they have stated that they will be addressing the audit process through sub-regulatory guidance, and as noted in the proposed rule, will selectively audit on an annual basis. They have clarified that they'll provide education to eligible clinicians and groups about data validation and audit process in time, but they haven't clarified or specified when that is going to happen. When I spoke to the vendor who actually performs the auditing on CMS's behalf, they stated that their counsel to organizations and to providers is to just be very explicit in keeping track of, on a patient level basis, your numerators and denominators when they do come through to do the audits. They're going to probably look at 60% of the measures that you submit data for, and of those, of the 60% of the measures, they're going to look at 60% of the patient data that supports the performance metrics for each measure. So you really want to be sure that you can tie back to specific patients your numerators and denominators for the performance categories. On the reporting requirements for the risk analysis assessment, we saw this was a one-off question that came through. I revisited the rule at the final rule at length, and do not yet couldn't find anything in the rule about this risk analysis assessment. So if the individual who submitted that is out there and can submit a follow-up question to Carol, or to reach out to us through our SA Ignite website, I'd love to have a chat and learn a bit more about what you're looking for, because I'm sure we can figure that out.
And Matt, I'll weigh in a little bit here myself. It's likely that they're referring to the security risk analysis portion of ACI, which you've done for years and years as part of the Meaningful Use program. The actual question about if there are reporting requirements for it is kind of curious, because I think that sort of connotes that you have to send something in. We don't believe that you do, and the requirements for the risk analysis don't change. Those stay consistent with the HIPAA regulations. So, but yes, just as Matt said, if there's any kind of follow-on and other information that people want, please don't hesitate to chat that information or chat that question in, and we'll get back to you on that. So I'm addressing the financial impact. It's always good to tell people they're going to get money. So are we eligible for the $500 million exceptional performance bonus if we only report for 90 days? So I think this is in reference to 2017, where the options laid out included reporting for 90 days as well as reporting for full year. So what we learned from CMS is there actually is not a difference. So 90 days is sufficient to receive an exceptional performance bonus. You must get 90 days, so 90 days is the minimum threshold in order for you to be eligible to receive that exceptional performance bonus. Is the maximum incentive for 365 days reporting 2.4%? So for those of you that weren't on the presentation last week, we had a chart that described how you can earn incentives in 2017, and we kind of outlined a graph that showed that the maximum estimated was 2.4%. So we want to put a caveat on that. So first off, back to my previous question, it does not have to be 365 days of reporting. But then secondly, that's CMS's estimate is 2.4%. That is based on the estimates of the number of people that they believe will be sharing in that $500 million of bonus money. So if there are fewer people sharing that money, then there will be more incentives for those few people. So that's part of why it's an estimate and not a final number. And then the last one is leads really well into the next section, which is, do provider-specific penalties go with the provider if they change practices to TINs? How does this affect pay for practices? So everything goes with the provider. So if the provider changes practices, then they will, their penalties come along with them. So if they performed in 2017 at one place, but then when the penalty or incentive is being applied in 2019, they're somewhere else, that will be applied at their new practice because that follows them.
Thank you, Beth. So I'm going to go through multi-location EHR clarification type questions. So very much as Beth said, kind of leading from the previous question, what is the MIPS impact on providers working in multiple locations or providers changing practices during the reporting year? So back to what Beth said, at the end of the day, the score and the adjustments, the reimbursement adjustments are always at the NPI level, regardless of how you report. It always trickles down to the NPI level. So multiple locations won't have an impact on the score, because if you're reporting individually, you're still going to be gathering the data for that one individual. If you're reporting as a group and those locations are under 110, I'm assuming you're not going to have an issue. If a provider changes practices during the reporting year, what CMS has finalized is that they will select the highest of the scores to be their one score used. So in the proposed rule, they had two options: the one that they ultimately selected, which is the highest of the scores, or a weighted average. And they determined for 2017, they're going to use the highest score, not the weighted average, for simplicity's sake, but did call out that in the future they're going to continue to analyze that. So there is no threshold, i.e., you must report X number of 6 months or more than half the year, any amount of reporting, and they'll take the highest score. Under MIPS, can we submit via different reporting mechanisms for different TINs? What about different locations within the same TIN? So a variation on something that we had talked about a little bit earlier, the reporting mechanisms have to be the same for a TIN within a category. So you would do EHR direct for quality, and that would be for the entire TIN. You couldn't vary regardless of locations. If for different TINs, then you're wide open again, because if you're reporting at that TIN level, the CMS views you as a separate entity, so no relation to each other. Have several sites, multi-specialty, which results in multiple data sets. Some of the sites will be part of CPC Plus program, which is an advanced APM. So for other sites and specialties, how do we submit for them? And what is the criteria with regards to submitting for the same TIN, but having data coming from two different data sets? So a couple questions in there, and a good example of how reality will be for a lot of practices. It will be some of your eligible clinicians will be participating in some variation of an advanced alternative payment model. CPC Plus is a great example, because with multi-specialty, it will only be part of that group because it's primary care. In those situations, the clinicians that are part of the advanced alternative payment model will be carved out. So they will be part of that advanced alternative payment model. They will be on the advanced alternative payment model track. They will receive the 5% bonus and will not receive the MIPS score. Everybody else within that TIN, all the other ECs within that TIN, then would be who, if you report as a group level, combine to create your group level score, or individually there. So it will create some interesting challenges from a tracking, management, and reporting standpoint based on how your group is split up. Pardon me. And then as far as submitting the same TIN but having data coming from different data sets, so ultimately that is on the practice accountability. So if you have two different EHRs or two different instances of an EHR, you have to combine that data. CMS will not do that. Now for 2017, you only need to report 50% of the data. So if you have two different systems, but one of those systems holds 50% or more of the data, then you could choose to just report it. Again, you'd have to go back to determine is that your best option based on the measure performance and what you would ultimately get the best score on. So moving to exceptions from a provider perspective. So first question, do PAs and NPs have to submit data in 2017 under MIPS? And the answer is yes. So the proposed rule had put out positions in mid-levels. The mid-levels include PAs and NPs, and the final rule did not change that. So the answer is yes, you do need to participate in MIPS. Can mid-levels still choose not to report ACI and get a possible incentive under 2017 options? So the answer is yes to that as well. CMS, to build some flexibility in, again, this on-ramp year, this transition year, said, since mid-levels have not done MU in the past, then they're going to provide flexibility for 2017 again as that transition year. So they can choose to report ACI, and if they do, it'll be scored and follow all the normal ACI requirements, category requirements, or choose not to report it as part of the transition year. And if they choose not to report it, then the ACI category weight is reweighted over to quality. So again, some analysis there to say what are my best options around how I choose to report. And then how are performance and financial penalties applied when a provider bills under another provider? So CMS is only recognizing the NPI where the billing is coming from. So from NPI's perspective, it is all the work of, or I'm sorry, from CMS's perspective, it's all the work of that NPI. This again will create some of those interesting scenarios where analysis will be need to be to determine, is that the best way to continue forward, or now do you have to change tactics based on this new reporting requirement and MIPS scoring and reimbursement adjustments? And Beth, I believe you're going to jump in on the determination of time.
I am. I was actually still thinking about the last question. Okay, so everybody get their pencils, continue to get their pencils right, because these are still kind of in the weeds and difficult to get your head around kind of questions. So the next one is, what time frame is used to determine if a provider is considered hospital-based? So it's basically, what's the timing and designation for hospital-based providers? And then the next question is around patient-facing or non-patient-facing providers. So hospital-based providers, they did lower the threshold to only 75% of claims would be coming from point of service 21, 22, or 23. And so they also added another point of service code that would count for being considered a hospital-based claim. So that's the kind of universe of data that will tell you whether or not the person is hospital-based. But from a timing perspective, what they said they wanted to do was do starting September 1st of the calendar year, 2 years preceding the performance year. So what they want to do is, so if you're performing in 2017, it would be September 1st of 2015 through 9/30 of 2016 would be that first year that would be used to assess hospital-based status, and then of course the second year would be part of that person's performance year. So that's the 2 years that would be considered the timing for determining whether or not the person is hospital-based. So it's relatively recent data. Part of why they wanted to go back 2 years was to provide you with information after that first year, provide you with information prior to the start of your performance year as to where that person stands. So by being able to report by September 1st of the year that you're going to start, before you're going to start reporting, you at least have a few months where you actually have some of that information in your assessment. So non-patient facing providers is determined very similarly. So it again is a 75% threshold, and those non-patient facing providers will again be assessed in this case first on that first year that I mentioned, and then secondly on that second year. So basically they're going to start by looking to see if that first year makes the determination, and if that doesn't make the determination, you can look in that second year of those 2 years to determine whether or not that person is automatically a non-patient facing provider. Both of those have implications in the ACI category, so that will give you different weighting to the rest of the categories if they are considered a non-patient facing provider. So unique reporting scores. I feel like I need a whiteboard for some of this. How do certain specialists still report with not enough applicable measures in quality? So what has been, as part, again, going back to that patient threshold, the number of patients that you're reporting, one of the things that CMS has put out is that as long as you report, even if you don't reach the patient threshold for all of those applicable measures, you will score at least still 3 points on that measure just for reporting. So by giving that leeway, that makes, for specialists for whom there aren't very many applicable measures, that makes them still be able to get some kind of score, even without having a full set of applicable measures. The other thing that they have done is the denominator will change in the quality category depending on the number of applicable measures. So if there are only 3 applicable measures over the 6 that would normally need to be reported, the denominator then is 30. And so you're only dividing what your score is under 30 versus under the full 60 points. And then I actually answered, I got ahead of myself, I actually answered the last question: will automatic exemptions be made for non-patient facing providers and therefore have their ACI category reweighted? So there isn't any special paperwork that needs to be filed. The categorization of these non-patient facing providers will be done prior, and you do not have to do anything. It would happen automatically.
So we have a number of different topics here under our special categories slide. Federally qualified health centers, RHCs, and CAHs. So the question is, under each of those, what's the impact of the rule? And it breaks into 2 categories. So FQHC and rural health centers can choose not to participate. And even if they do participate, they will not be subject to reimbursement changes. It is really just the opportunity for those eligible clinicians within those 2 groupings to participate, learn, receive data and feedback to improve, knowing that we don't know what will happen in the future, whether or not they'll be pulled in future roles or if they move on. So they can participate, but even if they choose to, it will not impact reimbursement. That is the opposite, though, for those participating as part of a critical access hospital. So for them, the MIPS payment adjustment would apply to payments made that they bill through their normal fee-for-service work with the physician fee schedule. So unfortunately, 2 different variations there to work with. Now, Medicaid eligible meaningful use providers. So first question, if I attest through our state under the Medicaid EHR program, will I be exempt from MIPS? The answer is no. So totally separate programs at this point, and there's no exclusion from one due to the other. Our practice currently reports Medicaid for most providers for meaningful use, but we also see Medicare patients. In 2017, will we have to report MIPS and Medicaid meaningful use? And the answer is yes. So the crossover there obviously would be the Medicaid meaningful use and the ACI category of MIPS. And because they are separate programs and now fundamentally separate other than some of the measure crossover, unfortunately there will be what a lot of people are calling dual reporting. So you will have to report Medicaid meaningful use, and you will also have to report the ACI category for MIPS. And then Medicare Advantage. Where does Medicare Advantage fall within MIPS? So right now, MIPS is all around Medicare fee-for-service business. So it does not include or have any impact, or Medicare Advantage does not have any impact on MIPS or quality payment program for the first 2 years. Potentially it becomes involved in the third performance year because CMS is going to expand what can be considered an advanced alternative payment model to models that are outside of CMS. So for the first 2 years, they all have to be CMS models, then it expands. And there is some anticipation that Medicare Advantage plans will be approved to help contribute to your thresholds to be considered part of the advanced alternative payment model track. So nothing now, but the expectation is it will be pulled in the next few years.
All right, this is Carol. Well, thanks for everybody for you guys for going through those questions, taking us through those questions, rather appreciate it. And of course, left some time for some new questions from the live audience. I do want to remind everybody that you will get a copy of this PowerPoint as well as a YouTube recording so that you can follow along and view this again. So we've got some time here left, enough for 5 or 6 questions, and so I'm just going to take these sort of randomly to throw it out and see what you guys have to say. First, clarification on one of the questions. To clarify, you can do claims for all years, then to decide. Excuse me. You can do claims all year, then decide to send all numbers via EHR reporting. No deadline in 2017 to decide. Beth, I think
that is correct.
Right.
Yeah. So if you are analyzing data via your claims all year long, but then your EHR data, that's coming straight out of your EHR looks really great, and you think, you know what, this is working and this is low overhead, I'm going to just send it this way, you can make that decision that can be a game time decision. You do not have to declare it ahead of time.
Okay. And just a clarification, when we advance to stage 3 MU measures next year, do we also report under MIPS? That's a stage 3 MIPS ACI timing.
Correct.
Yes.
So this is. Go ahead, Matt. Thank you.
Oh, I'm sorry. Yeah, and if I'm following correctly, MIPS and takes over for 2017. So from the CMS side, it is just MIPS. There is no longer a separate MU program on the federal side. For the state side, the Medicaid side, their MU program continues. So 2 different programs, but within the federal side, the CMS side, it is just MIPS with the ACI category.
And then
Alrighty.
in regard to the measures, just to add into in regard to the measures and the stage, so you'll see in the rule there's a table 9 and a table 10. One is the measures that generally align with the stage 3 measures, which will mean that you'll have to be on a 2015 certified system in order to be reporting with those measures. And then what they're calling the 2017 transition measures, which is in the other table, and those are based on the modified stage 2 or the 2014 certified system. So in 2017, you are not required to be on the 2015 certified system at that point, so you do not have to report those, quote, stage 3 measures. You'll be reporting modified stage 2 or measures based on modified stage 2.
Okay. Do you guys know, does the score which follows the clinician across all programs? For example, If an APM participant moves to a facility which reported MIPS, will the MIPS facility get the provider's APM score?
So I think there's a variation there. So the reimbursement does follow the clinician. There's not necessarily an APM score. If you're an advanced APM, you don't get a score per like a MIPS score, but you get the positive 5% reimbursement. Ultimately, what follows would be if you were not in an advanced APM, your score and your reimbursement would follow you. If you were in an advanced APM during the performance year, you would not have a score, but your reimbursement would follow you.
Okie dokie. Are CQMs as part of MU discontinued? That's a great question.
That is correct. So there is, as part of submitting the ACI category, there are no accompanying CQMs like you've had to do during the current meaningful use program. Because the quality category will kind of take over for that submission, there's no accompanying CQMs that have to be submitted for the ACI category. For 2016, you still have to submit them though.
Right. Please clarify, if you can, for providers who work at multiple practices.
So for providers that work at multiple practices, and I'm assuming by multiple practices, separate TINs, the provider would need to report across all of those TINs, so all of the data, and then CMS will select the highest score. So for instance, if there were 3 TINs, submitted 3 sets of data, CMS would take the highest score out of those 3, and that's what would be then his or her final MIPS score.
Okay, doke. Let's see here. Are there 2 different tracks for ACI?
Not sure I'm following what they mean. Okay, go ahead, Matt, because I wasn't following.
I think in the proposed rule there was a proposed an alternative because they were implementing some stage 3 measures in 2017, which was still an optional MU3 year. In the final rule, they do not have any MU3 measures involved, so there is only one path. You have your base measures, and then you have your performance measures, and you can choose which of those performance measures to participate, but they're all MU2 measures, so no need for a separate path.
Good. And sorry, I'm trying to get through as many of these questions as I can with what we've got with the time remaining. What is a practice split between reporting year and penalty year? What is a practice splits between? What if a practice splits between reporting year and penalty year? 1 TIN splits to 2 new TINs.
So, Matt, I'm going to try to take it, but if I get some portion of it wrong, please weigh in, or either of the Matts, really.
Sure.
So if it again follows the NPI, so if your performance is a certain, you have a certain performance in 2017 under a specific TIN, that actual value actually follows the NPI. So when it splits into 2 separate TINs in 2019, that's where your penalties or your incentives are being applied. That's still just going to be based on that individual provider score. So it's kind of irrelevant what their TIN structure is going forward.
Okie dokie. For mid-level providers, is the low volume threshold, that's the Medicare low volume threshold, determined by the amount of charges they bill under their own MPI, or do they count charges billed under a physician's MPI as incident to?
Beth, I can't speak to that one off the top of my head.
I don't know that one either.
Okay, we're gonna have to. We'll have to look into that. It's a good question. Let's see here. If a provider is now considered hospital-based, do we need to report as a hospital which still reports MU?
So I think what you're referring to is the meaningful use hospital program, the eligible hospital meaningful use program, which actually does not go away under MIPS. So if this person is considered hospital-based and so now will be contributing to the eligible hospital values, you don't have to do anything separate for that physician. That just means that that provider is not required to report under the ACI category of MIPS.
Okay. We're going back to slide 10. We report Medicare for our providers for MU, but also see Medicaid patients. In 2017, will we need to report both?
So the only way that you would be reporting both is if you've actually already started them in the Medicaid Meaningful Use Program, meaning that you've already gotten the eligibility requirements that would be such that you have a 30% threshold, or if they're a pediatrician, a 20% threshold of Medicaid patients, and have been starting to receive incentives on those programs. So if you have to have started the program in 2016. So if you did start that program, then it is in your best interest to try to report to both programs, because you'll still have some incentive dollars that you can earn under that Medicaid program. If you're just talking about you have Medicaid patients and you're just trying to figure out, I want to make sure I'm not doing something, you don't have anything that you're missing out on. If you have less than those thresholds, you just continue on in the MIPS program.
Okie dokie. So can we, before we end here, can the group talk a little bit about the improvement bonus points for subsequent years?
So they haven't.
Do you want me?
Yeah, go ahead, Matt.
The improvement bonus or the exceptional performance bonus? What was?
Yeah, I think that's what the attendee's talking about.
Sure. So the exceptional performance bonus there's likely going to be a fluctuation in the exceptional performance bonus depending on how the performance thresholds get set. So the exceptional performance bonus could fluctuate a bit depending on how they balance out the number of organizations that are above and below the performance threshold. For the first year, for this transition year in 2017, it's a bit lower than we'd anticipated based off of the information in the proposed rule, but it's likely to increase as fewer organizations qualify for the exceptional performance bonus. They therefore will have more money split up among a lower number of orgs. Matt, Fusion, what else can you add to that?
No, that's accurate, and not much more. It really is going to be determined year over year, and CMS will publish before the start of the year what the performance threshold will be for the upcoming performance year and what the exceptional performance bonus threshold will also be. So good news is we'll know both of those prior to the performance year beginning.
By 12/31. We still have many questions in the queue that we have not answered, and we are winding down here. So if you could and you would like to reach out to our three experts from SAIgnite on the presentation today, please email info@saignite.com and pose your question then, and mention in the email, of course, that you were attending today's event. Also, to remind everybody, a copy of this recording via YouTube video and the slide deck will be sent out to you certainly by Monday. And we will be back again in December with another ABCs of MIPS, probably talking about additional questions and probably hitting the APM side of it. Beth, Matt, thank you so much for your time today. I appreciate it.
Thanks, Carol. Great. Thanks for having us.
Yeah, we'll see you in December.
Thanks, everybody.
Bye.
Take care. Have a great week.
Bye-bye.